In this video, we'll review how to approach chest pain. For overview, we'll look at some of the chest pain etiologies. We'll talk about pain differentiation between types of chest pain. We'll do a deep dive into a chest pain assessment. We'll look at the actual chest pain approach and then review EKGs. The purpose of this slide is to show you that there are an immense amount of etiologies that cause chest pain. We're not going to review all of these. Instead, we're going to review some of the common etiologies and compare them to ACS, or acute coronary syndrome chest pain. The common etiologies list was chosen not only because these items are common, because they can also either become a life threat or mimic a STEMI on an EKG. We'll break down each one of these items individually and then ultimately compare them to ACS type pain. Pulmonary embolism. Think about patients that have had recent travel or recent surgery and shortness of breath as their primary complaint with chest pain as a secondary complaint. The chest pain will generally be focal. They'll be able to point to it, and it likely will worsen with deep inspiration or cough, but not always. What I want you to think about is if you have somebody that's short of breath and is tachycardic and you can't find anything else, no history of asthma or COPD, no lung pulmonary problems, they're not ill, none of that stuff. I want you to think about those scenarios when you can't figure out what's going on and you have shortness of breath and tachycardia as being pulmonary embolism until proven otherwise. Aortic dissection. This is classically taught as the patient will present with a tearing sensation or tearing pain. Of course, that's not always the case. So some tools to help you kind of differentiate. Generally speaking, the patient will present with pains that are sharp versus dull pains. On top of that, it's not going to be superficial, meaning the pain is not going to be close to the chest wall. With that, there'll be some posterior radiation, and because of the loss or change in blood flow due to the dissection, we might have some unequal pulses and also some neurological deficits. The neurodeficits are related to the loss in blood flow. That can be something simple as paresthesias like numbness and tingling in one extremity. Myocarditis / pericarditis. These patients will present with pain that worsens when lying supine, and the pain will reduce when they sit in Fowlers or lean forward. With that, they'll have some pain worsening on inspiration, generally deep inspiration, and they may have had some recent pulmonary illness like pneumonia. Pneumothorax. We're talking about spontaneous pneumothoraces, non-trauma related. These patients will present with a sudden onset of shortness of breath. The chest pain will be sharp and it'll be the secondary complaint, with the shortness of breath being the primary complaint. They may have had some recent coughing fits, probably severe and frequent, which would be the cause of the pneumothoraces. Also, these patients are generally very thin and very tall and male patients. For pain differentiation, I really want to focus on the acute coronary syndrome pain. Patients will present with descriptors like dull, heavy, or pressure-like chest pain. They'll be poorly localized, and they'll probably have some radiations, usually to the jaw or the left arm. Now with that, it's not going to change on the way that they position or when they breathe, and they won't be able to point to it. That's kind of guide you more towards it being ACS versus one of the other ones that we covered. I want to do a note here. For pleuritic chest pain, this is a type of pain and not a diagnosis. What's happening is the pleura and the thoracic cavity rub together, and this causes a sharp pain that's well localized. This can be caused from lots of things: pneumothorax, severe dehydration, on and on and on. This pain will also usually worsen with inhalation. Assessment. So like we saw before, lots of things can cause chest pain. So the assessment, a really good, thorough assessment, can lead you down the ACS pathway or away from it. So let's run through the OPQRST assessment. For onset, it's always taught about this post-exertion versus rest of the onset of chest pain. So let's talk about that. Exertional chest pain is really more defined as angina. They may have a narrowing artery, so the blood flow is insufficient. Once they rest and the demand goes down, the pain will resolve. That doesn't necessarily mean they're not also having an MI, maybe not a complete occlusion, but a partial occlusion, versus rest. Generally speaking, The way that we think about MI is someone has an artery with plaque built up, and a section of that plaque breaks off. The body then will clot over that section that's broken off and cause an occlusion. That's why the at rest is a higher risk of someone having ACS versus the exertional. Emotional states. Someone's getting divorced, or their child dies or is hurt. Those states, those extreme emotional states, can cause that plaque rupture and thus the MI. So don't think about that as being always not possible to have a secondary thing with the emotional state. Provocation. I think this is often overlooked during an assessment, but it's actually really important. Patients will attempt, especially men, will attempt to solve their chest pain issue, taking antacids like Tums or something like that, or maybe even pain medications, much Tylenol, ibuprofen, maybe even for days before, and that actually is important to pass along to the ER, or maybe in your assessment, because if they've given, say, someone has old Vicodin or Percocet, and they've taken that for the pain, that would probably change the dose that you're going to give for fentanyl. Positioning. Like we talked about before, the people in the myocarditis, pericarditis group, they want to stand up or sit up and lean forward versus laying down flat. So that the positioning questioning can help you lead you towards or away from ACS. For quality is really a pain descriptor. And again, the ACS is unique with those dull, pressure, heavy, words versus something like sharp. And that's, again, poorly localized. That'll all kind of help you guide you towards ACS. Radiation. It's also taught it's jaw and left arm. This isn't unique to ACS, but it will increase your chances of that using those components with the entire assessment to lead you down ACS. So if you think it's chest pain and they also have left arm radiation and jaw radiation, then it will increase the chances of being ACS. But of course, like I said, it's not always going to be chest pain. Someone could have a musculoskeletal issue that causes the pain. Severity for pain scale. I think this is taught for us. Just you ask it and it's going to define whether we give medications or not, but really it's actually useful. So if someone has 10 pain, I give them whatever medication, say fentanyl, and it goes down from a 10 to a 9, and I give them a large dose, and I give them another large dose, and it still doesn't change, then maybe try something else. That's true of always using for the pain scale. Versus if I gave them a little bit of fentanyl and it worked really well, then I know that's a good medication to come back to. Time. It's really important to ask, have they had this style of pain previously, a previous episode, or maybe a previous MI? Does this pain feel similar to that pain? What was the outcome? Did they get cath? Did they get bypass, etc.? Again, all of these components together makes a complete assessment. No one piece is really important. It's about the whole picture. Some additional notes for the assessment. Levine sign, that's when the patient takes their fist and puts it over their chest. That has a very low specificity, meaning that when you see that, that means chest pain. It doesn't. It's low. I don't have the exact percentage, like 40%, probably less than that. You can still use it as something to carry forward as a part of your assessment, but seeing Levine sign does not necessarily mean they're having MI. Diaphoresis, nausea, vomiting. These are really hard to fake. So if someone's complaining of chest pain and they're diaphoretic and they're complaining of nausea and they vomited, my index of suspicion for them actually having true ACS chest pain is much higher than if they're texting on their phone or they're telling you they're having 10 out of 10 pain with perfect vital signs. Chest pain approach. So in the first 5 to 10 minutes, let's talk about the priorities. First thing, 12-15 lead. You want to get a photo before you give any medications that can change that can affect it, like aspirin, nitro, fentanyl, etc. Then you want to get vital signs. Same as always. Start with a blood pressure. You'll already have the EKG on, SpO2, and then we'll talk about later, but entitled with oxygen. Next, aspirin. We're always going to give the full dose, the 324, because otherwise you have to verify the patient's bottle. Is it in date? How did they store it? Was it stored outside in the cold or the heat? Is the pill bottle mixed with Benadryl and you actually took wrong ones? So we always give the full dose. It's not going to hurt them to take potentially 2 doses worth. And that way you're guaranteeing that you have the right amount to actually affect them positively. Next, fentanyl. Fentanyl works in 2 ways. One, it actually will help reduce anxiety. It's got a small anxiolytic effect. and then next course, it reduces pain. Reducing anxiety and pain will reduce the myocardial oxygen workload or demand because the sympathetic tone is lower. Oxygen and end-tidal. The oxygen probably will not help the patient much, but it certainly won't hurt them. So a couple of liters I think is reasonable. We don't need to do high flow oxygen though, like a mask, and like that. The end-tidal is really good. End-tidal because these patients are at high risk for arrhythmias, which you may not see right away, but the end-tidal will alert if it drops or they stop breathing. So it's an indication, maybe a little bit sooner than the patient arrest, you'll get a drop in end-tidal. For the 10 plus minutes after that, we need to get additional IV access. Really 2 lines is preferred, 3 it could be better. The reason being is medications aren't necessarily compatible. So if you're going to be doing a nitro drip, or maybe they arrest and now they're on pressors, you need to have additional lines to be able to give the appropriate medications if something happens. You don't want to do that after something's happened. You want to have the lines ready before you have an outcome change. Next, don't delay transport. So think about where you are, what needs to happen, and what you can do en route. Last thing, you want to get that nitro infusion set up. We're really going to move away from tabs for chest pain. So don't do tabs for chest pain. We want to focus on giving the drip. It's better to wait a little bit and start the drip than to give somebody a tab. Tabs really don't have a place in ACS treatment pathways. Chest pain approach, some additionals. Medications. I think anybody that's having actual chest pain, it's a pretty common knowledge that chest pain, you can die from that. There's a pretty good associated amount of anxiety with that. Giving somebody a 0.5 Ativan can really help that. And what we're really talking about is reducing anxiety is going to reduce the sympathetic tone again, which will, of course, reduce the myocardial oxygen demand. If someone's nauseous, treat that like you normally would. Giving them Zofran can help make that better. If they're not nauseous, again, same thing, control that sympathetic tone. Stimulus control. Just like you don't like being in the ambulance, the patient doesn't either. Lighting, maybe they want it high or lower, whatever they want, ask them, set it to their demand. Temperature, whatever is best for them, if they're super diaphoretic or super hot or whatever, control it to the patient's desire, and then transport smoothly. There's no reason to drive fast. The smoother transport is not only safer, but better for the patient. For cardiac pads, this is a little bit subjective of how you decide to do this. For me, if somebody is 50 or younger, the pads go on every time. Doesn't matter. If they're having, I think it's real true ACS pain or having an MI, I'm going to put the pads on. Really short, the reason for that is something called collateral circulation has not developed when people are young. It takes a long time to do that. And so the older person is less likely to develop an arrhythmia than somebody very young. For serial 12 and 15 leads, I think in general, on a transfer, I think this is reasonable, just so you don't make sure you don't have a change. If you have a 5-minute transport, there's really no reason to do a serial 12, 15 lead unless you have a change, meaning I'm having 10 out of 10 chest pain, you gave me fentanyl and a nitro drip and now I'm pain is 0. That's a change. So then a serial 12 or 15 lead would be good. For EKGs, we're not actually going to review how to interpret them. More so, I want to point out something about 15 leads. Most of you have heard me say that if you're doing a 12 lead, you should do a 15. And we were lucky enough in the past to have a gentleman, Bob Page, come out. And based on his data, 30% of all 15 leads that will have a STEMI have a total normal left-sided 12 lead. So totally sinus, nothing on it. And you do a 15 lead and you'll see posterior involvement. So I just wanted to show here what more traditional 12 and 15 pairing look like when they have some problems. So looking at this 12 lead right here, we can see that there's a little bit of depression in V3 and V4, but otherwise it's a pretty clean 12 lead. Now if we roll over to the 15, there's some pretty obvious ST elevation in V7, V8, and V9. This is just the posterior section. There is not a V4R like we do at HGH. But I just wanted to show that neural pairing saw a little bit of depression, not necessarily even on the septal leads. And we look at the backside, and there it is, STEMI on the posterior section. This concludes the chest pain approach video.